In this video, Common Issues in Esteeming Peer Supporters, we will discuss external motivations for peer support, look at why peer support may be seen as low value, explore how a program may not be clearly designed and why peer specialists may not be valued, as well as review stigmas against recovery and the peer role in general. A peer support program is much more likely to be successful if there is an intrinsic motivation within the organization for taking on the peer support program, and much more likely to be minimized if the primary motivation is good press for having a peer support program or if it stems from external requirements. For example, in the article, Developing Strategies to Integrate Peer Providers into the Staff of Mental Health Agencies, Lauren B. Gates and Sheila Akabas wrote that, quote, "Finally, for some, the value of peers was minimized when the reason for the hire was externally motivated rather than driven by the agency's mission. Quote, the funder requested that we have a peer for the program. With an ACT team, the funder tells us what positions we should hire for," unquote. The perception of peer staff spans the spectrum of being perceived as having some value and being a nice addition to being expendable, a low priority, and or not being part of the agency's mission. Thus, it is crucial that peer support be championed by leadership as an integral part of achieving the organization's mission. The My Peer Toolkit provided by the Western Australian Centre for Health Promotion Research stated that while peer support has great potential and can be shown to be cost-effective in that it prevents more invasive and expensive interventions, peer support can still be seen as having low value. This can be because of CPS's association with informal peer support, which is generally done by volunteers, or the fact that CPS work tends to be low-paying. There can also be perceptions that CPS work does not contribute to an organization's performance measures or service statistics, that peers do not generate revenue, or that because of the general stigma that people with mental health conditions are of low value as employees.
A misguided attitude towards peer support programs comes from the idea that hiring peers can be a source of cheap labor by replacing more qualified mental health professionals. The article, Common Reasons Why Peer Education Fails, lists 3 ways in which this attitude can be a problem. 1. While peer specialists might be seen as costing less than other types of mental health professionals, they require a significant amount of upfront investment in order to be successful. 2. Peer supporters do not provide clinical services. They should be seen as an addition to, not a replacement for, other types of mental health services. Perpetuating this myth can also have the effect of increasing tension between peer supporters and clinical staff if the latter believe that peer supporters will, quote, take their jobs, end quote. 3. Peer supporters add an incredible value to their participants and the organization, both in outcomes and in monetary value. Instead of measuring peer support programs solely by the amount of money they bring into an organization, there should also be a comprehensive look at the cost effectiveness of how peer support programs can save agencies money and the value they add in improved outcomes.
When a program is designed by supervisors that are themselves not familiar with peer support, the program can end up with unclear goals or be designed in a way that is inappropriate for peer support work. My Peer Toolkit described that peer support programs can often face the issue of a lack of evaluation or an evaluation process that is misguided in its aims. Peer support exists to support outcomes best outlined by SAMHSA's value of peer support, but when organizations expect different outcomes from peer supporters, these programs will then be set up to appear as failing. Strategies against this outcome include making sure the supervisor is adequately trained in peer support and involving peer supporters in the evaluation process. In the article, Developing Strategies to Integrate Peer Providers into the Staff of Mental Health Agencies, Gates and Akabas explained that, quote, some respondents voiced the belief that having a mental health condition, by definition, meant that the individual was sick and, therefore, unable to give 100% performance in the workplace. They believed that peers were cheap labor who were unable to deal with the stress of working, whose presence on staff had the effect of dumbing down professional staff, who were unreliable, who could not go beyond their own perspectives, and who could not respond to emergency situations, unquote. This goes along with the theme of non-peer staff and supervisors symptomatizing or pathologizing peer support workers, meaning the tendency to regard any show of emotion or normal workplace stress as an indication of a person's mental health challenge. Furthermore, the article stated, quote, "For example, when a peer mentioned to a coworker that he found the enormous amounts of paperwork stressful and asked for advice on how to manage it, the coworker responded by asking him about his medication compliance," unquote. To combat this, it can be helpful for all non-peer staff who interact with peer staff to be trained on peer support and recovery topics.
Some non-peer staff still hold the belief that recovery is not possible for participants. This goes against the purpose of peer support work, and this differing worldview can cause tension between peer and non-peer staff on how to treat participants. In a 2022 study on the roles of peer support in a Swedish mental health context, the researchers said that, quote, "Sometimes there have been some clashes. I remember there was a patient who did not like his nurse. And then the team spoke about it, and the general opinion in the room was that you should not be able to change nurse because then everyone would want to. And then I protested. What is most important? I ended up in a situation. Should I be collegial or should I be on the patient's side?" Unquote. When a peer supporter who is trained in the recovery model is working alongside those who are against the concept of recovery, it can be alienating to peer supporters and actively make their jobs harder. A dissertation study on perceived effects of microaggression on peer support workers in mental health recovery stated, quote, "Participant 9 reported feeling inferior to a person mocking someone with mental illness in front of participant and other colleagues, which resulted in her inability to say something due to feelings of unworthiness," unquote. Managers should review their policies regarding discrimination, create policies regarding discrimination on the basis of recovery, and make it clear to employees what behavior is and is not tolerated.
When a CPS works for a supervisor and/or an organization that is unfamiliar with peer work, a CPS may be expected to do the work that is not appropriate for peer supporters. This can cause peer supporters themselves to be unclear about what their job responsibilities are. It may include misguided or unclear job descriptions. The article, "Developing Strategies to Integrate Peer Providers into the Staff of Mental Health Agencies," explained that, quote, "Comparison of written peer job descriptions provided by the HR representative or supervisor with the list of tasks that respondents actually performed showed that the expectations of peers were often unreasonable and greatly exceeded the formal specified job responsibilities. A supervisor recognized the fallout of this. Quote, peers have a flooding of tasks and they get overwhelmed. There are too many tasks for peers," unquote.
Because CPSs are sometimes misguidedly viewed as cheap labor, CPSs are at times expected to be available to fill in for whatever tasks need doing, even if they do not relate to peer support work. This can both give peers an unreasonable workload and cause them to fail in their mission. To this end, the article, "Developing Strategies to Integrate Peer Providers into the Staff of Mental Health Agencies," clarified that, quote, "When peer tasks overlapped those of non-peer staff, it left both peer and non-peer staff confused about their roles. It also led some non-peer staff to express concern and resentment toward peers. Non-peer staff felt that peers placed their jobs in jeopardy by fulfilling the same roles but as cheap labor. Peers felt confused because the unique contribution they could make was lost." End quote.
In addition to writing clear and accurate job descriptions for CPS positions, it should also be clearly defined for all staff what are the specific job tasks of peer and non-peer staff, where they differ, where they overlap, and when and how these two roles should collaborate. It should be clarified that these are distinct roles that aim to provide different types of support to best improve outcomes for participants.